Good evening. My name is Ziv Beckerman. I'm a congenital heart surgeon and I'm also the surgical director of the Adult Congenital Heart Program at the Texas Center for Pediatric and Congenital Heart Disease.
What is adult congenital heart disease and how common is it?
Every patient that was born with a congenital heart defect and is now an adult is considered to be an adult congenital heart disease patient. Some of these patients, actually most of them, had previous cardiac interventions, but some did not need any intervention during their childhood. Down syndrome patients frequently have congenital heart disease, and most of them will need ongoing care well into adulthood. To date, there are more adults than children living in the United States with congenital heart disease. Over 1.4 million adult congenital patients are alive in the United States alone, and more than 40,000 congenital heart disease patients turn 18 every year.
Why should an adult with adult congenital heart disease be followed in a congenital cardiac center?
Most patients with congenital heart disease are not cured of their disease. They get sick more often than the general population. Lifelong follow-up is needed, but 30 to 50% are lost to follow-up as they turn into adulthood. Certain congenital cardiac centers, like the Texas Center for Pediatric and Congenital Heart Disease, had developed the required support systems to care for adults with congenital heart disease. Adults with congenital heart disease are very much different from adults with acquired heart disease. Congenital heart centers are familiar with all the different nuances of care that congenital heart patients require. According to the American Heart Association, about 10 of every 1,000 babies, or 1 out of 100, is born in the United States with a congenital heart defect. Congenital means that it was present at birth. This is a problem that occurs as the baby's heart is developing during pregnancy before the baby is born. Congenital heart defects are the most common birth defects, and they can range from asymptomatic to fatal. About a quarter of the babies with congenital heart defect will need an intervention in the first year of life. In the first years of surgery, back in the late 1800s, early 1900s, cardiac surgery was not considered possible. Even some of the most famous surgeons of the time thought that cardiac surgery should never be attempted. The presentation of a baby or a child with congenital heart defect or disease may vary quite significantly. At times, it can be an innocent murmur that may be heard during a doctor's appointment. Other times, it may be in extreme conditions where the child may be very sick, presenting with heart failure and even shock. One of the more common presentations some 20 to 30 years ago or more was of cyanosis. That is, when there is insufficient oxygen in the blood due to inability of enough blood to get to the lungs to receive oxygen. The team presented in this slide is comprised of 3 people: Dr. Blaylock, a general surgeon, Dr. Tausig, a pediatrician that focused on the heart. At that time, there was no such thing as a cardiologist, and Vivian Thomas, a lab technician. In the early 1940s in Johns Hopkins Hospital, Dr. Tausig approached Dr. Blaylock with the exact problem that we mentioned before: blue babies. That is, babies which don't get enough blood to the lungs to oxygenate. These babies at that time used to succumb to their disease in a matter of few weeks or months. Dr. Blaylock decided to take on this challenge, and together with Vivian Thomas, they came up with a solution.
You must have got it. Oh, Vivian! It's working at a hospital, right?
Yeah.
Everyone's gonna see how smart you are.
Vivian, Dr. Blaylock wanted you to have this.
Excuse me, all workers punch in at the rear entrance.
He's with me.
I'm sorry, Dr. Blaylock, but that's the rules.
We got a blower
face.
I don't think that she's breathing right now. I don't think that she's breathing.
That baby back there, how long?
6 months. Are you going to take this on, doctor?
No one's ever done anything as hard as this.
You can't operate on the heart. That's basic.
There must be a way to get more blood to the lungs.
We focus on the pulmonary artery.
Who on this God's earth are you?
You got that white coat. You just a class 3, work the same as me.
I'd like some coffee and a donut.
What about you going to medical school?
You don't have to remind me of that, Clara. We have a family now.
Let's start with experiments. Let's break their rules. You can begin the incision.
I'm not ready for that.
If I say you're ready, you're ready.
You have to see this. Vivian Thomas is operating, assisted by the chief of surgery.
Retract.
No suture.
Can't we try things my way occasionally? I think we've found a way to repair your daughter's heart.
Your quest for glory is vain. Postpone the operation until you have more experience.
Postponing means signing that baby's death warrant. I'm operating tomorrow. Page Vivian Thomas.
What's wrong? What's happened?
Paging Vivian Thomas. You want it in OR right now. You're talking me through this. Scrub up.
What's he doing?
You can resume your duties.
These are his duties. We made history together. We changed the world.
The intro that you just saw is for a movie called Something the Lord Made. The movie tells a true story of Dr. Blaylock, Dr. Taussig, and Vivian Thomas. And together, this amazing team performed what is known to be one of the first heart surgeries to take care of cyanotic or blue babies. Subsequently to their amazing work, this was one of the first papers published on managing this very dangerous and life-threatening condition. The baby seen here is one of the first babies cared for and treated with this specific methodology or specific operation that you just heard of. So operating outside of the heart is one thing. As you heard, like the palliation done or the treatment done for the blue babies. But how can one operate inside the heart without stopping the heart? So that's practically impossible, right? Once we open the heart, blood will come out. The only way to achieve that is if you have some machine that can provide blood to the body while the heart is not working. Such a machine is called a heart and lung machine. Early in the years, earlier in the century, there was no option, there was no heart and lung machine, so such operations were not possible to be undertaken. But that changed with time. In the early 1950s, one of the first attempts were made to perform an open heart surgery while cooling the patient, what we call hypothermia. The patient, the baby, typically was placed in a bathtub with ice water. Then subsequently was lifted cold and wet into the operating table. That allowed about 6 to 10 minutes for performing in repair inside the heart, which is an extremely short period of time. That technique was, for obvious reasons, rapidly abandoned in favor of the heart and lung machine. In 1954, Dr. Lillehei, Walton Lillehei from University of Minnesota, reported a first of a kind experiment at which he took a human being, typically the parent of a young patient, young baby or young child, and used the parent as a heart and lung machine. He connected the circulations of the two patients, and as such, the dad or the mother served as a heart and lung machine, having a heart pump and lungs as an oxygenator. In this picture, you can see a group of surgeons or caregivers operating on the child on the left side, and on the right side you can see another patient with tubes connecting to his groin. The patient on the right is the adult, basically the heart and lung machine, and the patient himself is on the left side of the picture. So how do things look today? A little bit different. So the operating room is structured differently. Still a lot of people caring for a single patient, but we have all sterile technique. We have a heart and lung machine which sits just in front of the surgeon. We have an anesthesiologist or an anesthesiology team at the head of the bed caring for the patient. The surgical field itself is nice and tidy, and the surgery is meticulously done, and we have the luxury of doing prolonged operations today inside the heart while maintaining adequate blood supply to all the body. This is how a kid or a baby is looking in the recovery room or in the intensive care unit after surgery, monitored by multiple devices. Everything is very well arranged and organized, clean and neat. This is how the baby looks while he recovers in the crib. And hopefully this is how they look when they go home. As the years pass, the babies which we operated on as babies or newborns will grow and develop into adults. Their hearts may be fixed forever, or they may need other interventions as they age. As we mentioned at the beginning of this presentation, they become what we call adult congenital heart patients. So to re-emphasize and repeat partly, adult congenital heart disease can comprise two main groups. One are patients born with congenital heart defect which were operated on, sometimes more than once, and they survived into adulthood and now require an intervention. The others are patients born with congenital heart defect but was either never diagnosed or never required an intervention, but are now adults that may require one. So how does this journey to survival look like? Prior to the 1940s, children with severe congenital heart disease had more than 80% chance of dying before reaching adulthood. Today, more than 90% of them have a chance of surviving well into adulthood. How did we get there? That was a very complex road which comprises many interventions along the years. Anywhere from being able to diagnose the problems as in the fetal life, to advances in neonatal intensive care, medication, improvement of surgical techniques, ability to do early complete repairs of the heart, even on tiny babies. All those attributed to the lower mortality or death rate around the surgery, and further down the road, improvement in the ability of us to do reoperations and treat other complications like rhythm problems. All these together led to the expansion of the population of adults with congenital heart defects. Most patients with congenital heart disease are not cured of their disease simply by operating or treating them. They get sick more often than the general population and have a higher risk of death. Most of them are self-supporting, but others have physical and cognitive limitations that make it impossible for them to be self-supporting, and they need a lot of help in their life. They need a lifelong follow-up, but we know that about 30 to 50% of them are lost to follow-up in adulthood. There are currently, as we said, more than 1.4, other numbers predict about 1.5 to 1.6 million adult congenital patients in the United States alone, which is actually more than 50% of all the congenital heart patients. So right now, there are more adults with congenital heart disease than there are kids and children, babies. The adults have 3 to 4 times higher rates of visiting the emergency room, of hospitalizations, of intensive care unit admissions, comparing to the general population. There are many barriers for effective care for the adult congenital patients. There is a lack of sufficient dedicated adult congenital facilities. The care is fragmented between the primary care physicians, the adult cardiologist, and the pediatric cardiologists. There are not a lot of adult cardiologists that have congenital heart disease education. And the lack of coordinated management of contraceptives and pregnancy needs, which is a significant problem among this patient population. Adults with congenital heart disease have several trajectories in their life. Some congenital heart disease, as we said, can be repaired, meaning that either via a single or multiple interventions that result in a repaired heart, meaning a heart with no residual problems. Others are palliated, meaning the heart is temporarily fixed and it can serve its function for a certain period of time. But what happens when the heart fails, either early or late in the pathway? Once heart failure subsides and needs to be managed, there are several options, medical options for us to provide. One would be medical care, medications. Others are mechanical circulatory support, meaning we implant some device in the body that would help the heart's function. And the last solution is a heart transplantation. There are several mechanical circulatory support devices. They can be either devices which are placed through the chest wall cavity and connect to the heart itself, like the Berlin X-Core. They can attach directly to the heart, like a hardware or heart-made device. And others can be placed in the catheterization lab, going through one of the arteries or veins in the body. All these devices are temporary. They can be short-term or they can be longer-term, but they're still temporary. Some of them may function for several years, but there are none that can provide lifelong support. So the only solution we currently have for a longer-term support is a heart transplantation. This is a baby's heart, and we can implant new hearts in newborn babies or in adults. This is one of the first, or the first, heart transplant recipient in Dell Children's that we operated on about close to almost, it will be soon a year ago. He is an 18-year-old patient that spent a very long time in our intensive care unit until getting a heart available. And here he is walking out of the hospital with a big smile under his mask. About 3 years ago, we opened the Texas Center for Pediatric and Congenital Heart Disease, which is a clinical partnership between Dell Children's Medical Center and UT Health Austin, the clinical practice of the Dell Medical School at the University of Texas at Austin. The Texas Center for Pediatric and Congenital Heart Disease is the only pediatric program in Central Texas offering comprehensive heart care for newborns, infants, children, adolescents, and adults. When we opened the program, the goal was to rethink congenital heart disease. That means to redesign the care of patients and families with congenital heart disease by developing a model system of health delivery that is integrated, holistic, patient-centered, value-oriented, and technology-driven. I would like to thank you for the opportunity to tell you a little bit about congenital heart disease and adult congenital heart disease, and I'm looking forward to answering any potential questions you all have. Thank you.